It's my privilege to be here and to be invited to Traverse City to give your noon conference today. And my goal is to keep everyone awake and to educate you on evidence-based transfusion practice. So this is where I'm from, Baltimore, Maryland, Johns Hopkins. I'm an anesthesiologist there. I run our hospital's blood management program, and this is our new clinical building. The money for which came from Sheikh Zayed, United Arab Emirates, for the left side of the building, and then Michael Bloomberg from New York City for the right side. So the Jewish and Arab philanthropists came together to give us a new hospital, and we're very grateful. Oh yeah, and I must tell you that Baltimore, Maryland is the greatest city in America. It says so on every bench on every street corner, so you don't forget. This is me doing my favorite case, which is a liver transplant. We did 136 livers last year, which makes one every 3 days. So I give my share of blood, no doubt. This is me sitting on 15 units of red cells and 15 units of plasma, making sure that it's utilized appropriately. But any good talk has to begin with a disclosure slide. So I have been a consultant for 2 companies listed here. This is my source of funding. I will mention off-label use of one drug, which is tranexamic acid, to reduce bleeding and transfusion during surgery. But perhaps the most important disclosure that I need to make is a potential bias in my talk, because I personally had a life-saving transfusion in 1988, and we'll start with that story. So this is me. I was a third-year resident in anesthesia. It was a bicycle versus car head-on collision. I was helicoptered to shock trauma for an emergency splenectomy. And if it weren't for 6 units of blood, I wouldn't be standing here right now, because I calculate that I lost about 10 units, which is an entire blood volume, and I left the hospital with a hemoglobin of 7. So there's no doubt that blood saves lives, especially during hemorrhage. In fact, we're told all the time, give blood, save a life. You can see this sign in our hospital elevator. So you might think that giving more blood is better, right? Because it carries oxygen. It must be good for you. However, in the last decade, you can see this is the national trend for blood utilization. Transfusions are down 25% in the last 9 years. So why is this? Why is blood use so dramatically decreased in the last decade? And why are blood centers like the Red Cross and other blood centers hurting as transfusions decline? There's blood centers that are closing or merging just to stay alive. So why is this? I hope to show you why this is happening in the next few slides. Part of the story begins in 2012 when the Joint Commission held an overuse summit, and they identified not only that blood transfusion was the most commonly performed procedure in U.S. hospitals. How many people knew that? And also one of the top 5 overused procedures, right up there, for example, with antibiotics for the common cold and heart vessel stents, which were in the New York Times last week, by the way, as an overused procedure. And so this is based on evidence, not just opinion, and I'll show you the evidence in a minute. So in 2013, along came the Choosing Wisely campaign, which is a national campaign to reduce unnecessary tests and procedures. And now we have 6 societies with Choosing Wisely aims to reduce unnecessary transfusions, including the intensivist, the anesthesiologist, the hospitalist, the hematologist, the OB/GYN docs, and even the blood bankers have choosing wisely aims to reduce unnecessary transfusions. So one of the best things about blood management is we can achieve all three of these at the same time. We can reduce risk, we can save cost, and improve outcomes. And we'll go through risk, cost, and outcomes in the next few slides. So I like to divide the risk of transfusion into these three categories: the rare events, not so rare events, and then common side effects of transfusion. So nowadays, for example, hepatitis C and HIV are considered rare, about 1 in 2 million transfusions. So that means only 8 people in the United States should get HIV this year from a blood transfusion, which is fine as long as you're not one of those 8 people. But people forget about the not so rare events like TRALI, transfusion-related acute lung injury, which is a cytokine-mediated inflammatory response in the lung due to HLA incompatibility. And TRALI is the #1 cause of transfusion-related death. It's thought to be 10% fatal. Hemolytic reactions from the wrong units being given, much more common than HIV. And TACO, transfusion-associated circulatory overload, which is the #2 cause of transfusion-related death, is very common, about 1 in 100 transfused patients. So people forget about these much more common risk of transfusion. In fact, hepatitis C and HIV, the risk from transfusion has been compared to the risk of getting struck and killed by lightning. So Jeff Carson did a serious study where he looked at the risk of lightning deaths in all 50 United States. And he found that in Wyoming, that they had the highest risk of lightning strikes. So getting hepatitis C from a blood transfusion is like living in Wyoming and getting killed by lightning. So people take home the wrong message that blood is so safe that we can just give it to everybody, but they forget about TACO and TRALI, for example, #1 and 2 causes of transfusion-related death, which are much more common. So what about cost? So this is what we spend each year for blood acquisition cost in the Johns Hopkins health system. So we spend about $28 million a year, which is $1 million a month on red cells, $1 million a month on platelets, but only $1 million a year on plasma and cryoprecipitate. So you can see if we can reduce our blood spend by 10%, for example, that we can save almost $3 million in cost. And you should know that blood is either poorly or not reimbursed the way we're paid in medicine nowadays with the bundled DRGs that we're paid under. And you should also know that the true cost of blood is 4 times higher than what I show here, because there's 70 steps between the donor and the recipient. And if you put a price tag on each one of these steps involved with bringing blood from donor to recipient, it's 4 times higher than the blood acquisition cost. So when you talk about hemoglobin transfusion triggers for red cells, we probably have more evidence from landmark studies, randomized trials, than almost any other practice in medicine. Because where else do you find 8 landmark studies in the New England Journal or JAMA to support anything that we do in medicine? So here's the 8 landmark studies. They've been performed comparing lower versus higher hemoglobin triggers in a variety of different clinical settings. The lower triggers that these studies support are either 7 grams per deciliter or 8, shown here on the left. The 8 is for the 2 studies in patients with cardiovascular disease. And when they compared to higher hemoglobin triggers of 9 or 10, shown on the right, they found either the same outcome, meaning no benefit to giving extra blood, or worse outcome in 3 of the studies, meaning actual harm to giving extra blood. So this is where the number 7 comes from, and then 8 in cardiovascular disease. And note that even the critically ill ICU patients in the TRIC trial did as well or better with a hemoglobin trigger of 7 than they did at 10. So even the sickest patients in the hospital can tolerate what we call a restrictive transfusion strategy. So why doesn't giving extra blood help? You think it would carry oxygen, it would help patients recover. Well, one of the reasons might be what we call the storage lesion. And that is what happens to red cells over 42 days of storage in the blood bank, because 6 weeks is now the FDA shelf life of red cells. And it turns out that the red cells don't get better with age. They're kind of like milk in the grocery store as opposed to a fine wine. So this is what red cells look like on day 1 when they're donated, and then after 3 weeks, and then after 5 weeks of storage. And you can see they're spiculated, echinocytes and spherocytes. They just look damaged, if you will. In fact, the membrane of the red cell becomes less deformable, so it has trouble changing shape. 2,3-DPG, which allows hemoglobin to deliver oxygen, is about 95% depleted after 2 weeks of storage. Nitric oxide is depleted. The cells become more adherent to endothelium and more aggregable or prothrombotic. So the membrane deformability is important because the red cells are about 7 microns in diameter, and they travel through capillaries that are as small as 5 microns. So they have to change shape to get through small capillary beds. And you can see they almost have to go through in single file to get through the capillaries. So deformability is important, and when the cell membrane is stiffened, that's a problem. So we measure deformability with an ectocytometer in real patients having real surgery. Deformability is on the y-axis here, so higher is better and lower is worse. And we looked for 3 days before, during, and after surgery, and we found if they got 2 or less units, that's minimal transfusion, they had a small change in deformability. But if they got 3 or more units, that's a moderate transfusion, they had a loss of deformability. And by the way, that loss was not reversible. So on day 2 and day 3, they didn't recover normal membrane deformability, so it might be a permanent injury to the cell membrane. What about clinical studies comparing new blood versus old blood? We call this the age of blood studies. Well, this whole field was started by Colleen Cook, who's my department chair, by the way, when she was at the Cleveland Clinic in 2008. She had this New England Journal article that showed that cardiac surgery patients who got older blood had a 2-fold increase in mortality when they got blood stored 20 or more days compared to 10 or less days. So this triggered a cascade of randomized trials, tens of millions of dollars of studies, and there's been 5 randomized trials since then that were all negative, by the way, comparing fresher blood to older blood and finding no difference in outcomes. So the Red Cross breathed a sigh of relief, and these were done in neonates, cardiac surgery, ICU patients. However, they weren't allowed to give the oldest blood in the bank because the IRBs didn't think it was ethical to randomize patients to get the oldest blood in the bank. So we looked at the oldest blood in the bank at our institution, and we drew the cutoff at 28 days and then at 35 days, so the last 2 weeks of storage. And we found at 28 days, we found no difference in outcome, but at 35 days, especially in the ICU patients, so the sickest patients in the hospital, we found increased morbidity and increased mortality. So we think giving the oldest blood in the bank to the sickest patients in the hospital is a bad idea, but otherwise middle-aged blood seems to be just fine. So one of my areas of interest is collection of data to improve practice from electronic records. And I was asked to give a talk to the Red Cross about 5 years ago on data collection. And this is what we concluded after my talk: that medicine lags behind fast food restaurants and auto parts stores in automating data collection. And I give an example that until very recently, about half of US hospitals were still using paper anesthesia records. So this is what I call the old-fashioned paper anesthesia record that we used until 2009. You can see right here is where you chart blood, and it's virtually impossible to collect data from paper records. If you've ever tried, you might agree with me. And then in 2010, we went to the electronic record where all the blood units were entered, as were the hemoglobin levels and all the lab tests that we send. So we decided to query the database, and at Johns Hopkins, we ranked all the surgeons on the left, and we ranked all the anesthesiologists on the right according to their average hemoglobin thresholds for transfusion. Okay, so hemoglobin's on the x-axis, and the left edge of the red bar is the hemoglobin trigger, or the average hemoglobin before the transfusion. The right edge of the red bar is the hemoglobin target, or the hemoglobin after transfusion. So we found this wide variation in practice, about a 3-gram variation among providers. And our publication was written up in the media about this wide variation in blood transfusion practice during surgery. And they said there's a need for improved blood management. And note that this came out in the business section of the paper, because they also noted a huge cost savings opportunity if we could reduce the variation in practice. So we took the hemoglobin threshold graph and we put names on the y-axis. And then people paid more attention. We did the same for anesthesiologists as well. And we superimposed the shaded range up the middle, which is where all the red bars should fall according to the 2 biggest randomized trials in the New England Journal. And you can see we had a lot of over-transfusion going on back in 2010, 11, and 12. A lot of red bars to the right of the shaded range. So then we put the data on the door, the bathroom door, and then people really paid attention, because when you put doctors' names on a ranked order bar graph on the bathroom door, they'll line up to see where they fall compared to their peers. And that's what they did. Everybody wanted to know where they stood on the curve. And this is the anesthesia office bathroom door, by the way. So not truly public. And I tell a story at this point about my favorite surgeon at my institution, surgeon number 44, because he's here at the bottom of the hemoglobin curve. He had the highest hemoglobin in the hospital in his transfused patients, and I sent him a message to tell him he had the highest hemoglobin. And he's one of our most senior surgeons. He's done over 2,000 Whipples. And I sent him this message on Christmas Day, by the way. I had nothing else to do. And this is what he told my colleague in his next Whipple. He said, if you hang that blood, Steve Frank is going to be all over our case. So he loved giving blood, by the way. And he did a 180 because he either heard about the bathroom door or he didn't like being on the edge of the curve. And until we looked at the data, he had no idea that his hemoglobin level was 2 or 3 grams higher than his peers until we looked at the data. And this is his transfusion rate since we showed him the data. He had a 55% decrease in red cell utilization, and surprisingly also a decrease in plasma and platelets. because a lot of providers now, they believe in this 1-to-1-to-1 ratio of red cell to plasma to platelets, which is supposed to be for massive transfusion, not for minimal or moderate transfusion. But nonetheless, we saw a decrease in all three of the blood components. The other use for electronic record data that we've shown is to improve the process of ordering blood before surgery. That's type and screens and type and cross. So we had what I call a shotgun approach to blood orders before this project began. So anybody and everybody could order a type and screen or cross whether or not it was needed. So we took 2 years worth of data from the electronic records, and we updated our surgical blood order schedule based on real data, and we showed a potential huge cost savings to reduce unnecessary blood orders. And I blow up urology as an example here. So the bigger cases still get a type and cross. The medium-sized cases, if you will, get a type and screen. And then the cases that are rarely or never transfused, we recommend no blood sample at all. That's no type and cross, no type and screen. And God forbid if they get into a bleed unexpectedly, guess what? Remember in medical school they taught you that O negative was a universal donor? Well, that's still true. And you can give any patient, anytime, any place, what we call emergency release blood with very low risk. So perioperative patient blood management has been called giving the right dose, the right product to the right patient at the right time. But it's really more than that, and I've outlined 10 different methods of blood conservation, if you will, that I'll review in the next few slides. For example, treating anemia before surgery. If you can give $5 worth of iron pills, doesn't that make sense to avoid $500 worth of blood? Plus, they show up with their own red cells instead of requiring the stuff from the blood bank. Sometimes we even get aggressive with intravenous iron or erythropoietin for specific cases. Less invasive surgery. One of the reasons blood use is down across the United States is, for example, robotic prostatectomy. Okay, when I did prostatectomies as a resident, when they were open, they all got 2 or 3 units of blood, every patient. Now with robotic prostatectomy, we've transfused 1 patient in 800 cases. Okay, so virtually never transfused. Same with endovascular repair of aortic aneurysms. Okay, now they put in these stent grafts through the groin. They don't have to do an open aneurysm repair. So surgery is definitely less invasive and less blood shedding, if you will. The cell saver, I'll show you what that looks like. That's been called the centerpiece of blood conservation, where we collect the blood patients lose during surgery and give them back their own blood. Newer cautery devices, minimizing phlebotomy blood loss. I'm going to show you how much blood your patients lose in the ICU each day to lab testing. We're going to talk about clinician decision support. Those are the annoying pop-up alerts that you get when you try to order things. Antifibrinolytics. We'll talk about tranexamic acid to reduce bleeding. Point-of-care testing. Anytime you get a rapid turnaround on your lab test, you're less likely to give unnecessary blood because you're not left waiting and wondering if the patient needs a product if you have a rapid turnaround. Audits with feedback and education like we're doing right now. So I'm a cyclist, and I sometimes give my patients erythropoietin to treat pre-op anemia along with IV iron. And I tell my patients this is the same drug that the professional athletes use to build their blood count, only you won't get in trouble for using it, and it works really well. The cell saver. So it was conveniently invented in the mid-1970s, right before the HIV crisis. So in the 1980s, everybody wanted cell-saver blood because the blood bank blood was such high risk, especially for HIV. And the cell-saver remains a centerpiece of blood conservation. In fact, who wouldn't rather have their own cells back compared to someone else's blood from the blood bank? Plus, the cell-saver blood is fresh. It's only been outside the body for an hour compared to blood bank blood, which has been stored for up to 6 weeks. So we looked at the quality of cell-saver blood by measuring 2,3-DPG levels, which allows the hemoglobin to deliver oxygen. And we found that the cell-saver blood in green had normal levels of 2,3-DPG, just like fresh blood shown in dark blue. But the stored blood, or the banked blood, in light blue had a 90% decrease in 2,3-DPG, and it turns out that causes a left shift in the hemoglobin oxygen curve with a lower P50. So here's the hemoglobin oxygen curves that we measured. In the banked blood, or the stored blood, there's a left shift, but in cell-saver blood, it was identical to the fresh blood. So the left shift impairs ability to offload oxygen. So we think that cell-saver blood is higher quality than banked blood. In fact, that paper was written up in the media, and they called the cell-saver blood recycled blood, and they said that it was better than donated blood for transfusion, and that we recycle a lot of things, paper, plastic, and metal, but we also can recycle blood, give patients back their own blood. So we took a survey, if you will, of the 5 adult ICUs at Johns Hopkins to see how much blood patients were losing to phlebotomy for lab testing. And it turns out in the average adult ICU, about 60 mLs a day are either sent to the lab or thrown in the trash for clearing the lines of saline. So 60 mLs a day is just over 1% of your blood volume, which is, by the way, how much erythropoiesis you have every day. You destroy and recreate 1% of your red cells every day. So you're basically canceling out erythropoiesis by sending that much blood to the lab from the ICUs. In the neurocritical care unit, they cut that blood loss in half with this $9 device to return the wasted discard back to the patient. And we've also switched to smaller phlebotomy tubes. Based on this study by Colleen Cook, who is my department chair, when she was at the Cleveland Clinic, she wrote this paper with a provocative title called Contemporary Bloodletting in Cardiac Surgical Care. And she said she was astonished by the amount of bloodletting because some patients in the ICUs were losing up to 1 or 2 units worth of blood just due to lab testing. So we've switched to smaller phlebotomy tubes, these pediatric tubes in the middle, which hold 2 to 4 mLs. The adult-sized tubes hold 5 to 10 mLs. And sometimes we use neonatal tubes, which hold only a half ml. But the lab doesn't really like these tubes because they don't fit through the machines, and they have to be run by hand. So we pretty much use them for neonates and Jehovah's Witnesses. The annoying pop-up alert. So I don't like them any more than you do, but I built this one, and this is in our EPIC system, and it's the red cell transfusion best practice advisory. And if your patient has a hemoglobin measured that's greater than 7 in the last 24 hours, you get this pop-up alert when you order a red cell transfusion that says that your patient might not need the blood. And then we give 2 New England Journal references as hyperlinks, which you can read as a full text article. This is the TRICK trial, the most famous blood study ever. and then the focus trial to support our advisory. And then if you want to proceed with the transfusion, you pick a reason. The most common reason that people choose is active bleeding. If patients are actively bleeding, you have to stay ahead of the bleed, and the hemoglobin trigger might be higher. Second most common reason is symptomatic anemia, which is tachycardia, hypotension, or dyspnea. So we found that education plus these decision alerts, they work well together. We've managed to decrease the monthly number of out-of-guideline transfusions from 1,000 units a month to 400 units a month for red cells. That's a 54% decrease. At the same time, we saw a 14% decrease in overall red cell utilization in units per patient for the surgical services in our hospital. So tranexamic acid is an anti-fibrinolytic drug. It's been around for 50 years. It's in the same class as aminocaproic acid, or Amicar. But TXA is being called the game changer at the national orthopedic meetings and at the blood meetings as well. It's being given because it stabilizes clot and prevents its breakdown. That's anti-fibrinolytic. And it reduces bleeding and transfusion by about 30%, especially for orthopedic cases, cardiac surgery, and some of the major vascular cases that we do. When we started giving TXA for joint replacements, for example, we had this dramatic decrease in blood utilization. But at the same time, we hired 3 new surgeons, and the focus trial came out in the New England Journal supporting lower hemoglobin triggers. So multiple things changed at the same time, as does anything in clinical medicine. But tranexamic acid is hot, and these are 2 of the largest randomized trials ever in the history of medicine. Each of them has 20,000 patients that were randomized to tranexamic acid or placebo. The top study, the CRASH-2 study, was done in hemorrhaging trauma patients, and they found that tranexamic acid reduced mortality between 10 and 15%. And the bottom study, called the Woman trial, just came out this year in May, was in postpartum hemorrhage. Again, 20,000 postpartum hemorrhages randomized to tranexamic acid or placebo, and they found an even greater decrease in mortality, between 20 and 30% decrease in mortality, especially if you gave the tranexamic acid early during the postpartum hemorrhage. This was written up in the New York Times, by the way, the Woman trial, and they talked about giving $7 worth of drug to save a life from postpartum hemorrhage. That's what it costs in the third world countries. A gram in this country costs $36, but if you can do that and save a life, it sounds like a good deal to me. So our blood management program is very data intensive. So we built these dashboards for blood management using data from Epic. And we have all 5 hospitals in our health system on the dashboard. And we have red cells, plasma, platelets. We have single versus double unit transfusion orders. We have hemoglobin triggers. And I'll show you how our dashboards work, because we use them to generate reports that we send out every month. And so this is a report that we send out to each department every month. And I use orthopedics as an example. So on the y-axis are the individual orthopedic surgeons by 5-digit codes, and on the x-axis is the number of blood units that they gave for this time period. But more importantly is the proportion of those blood orders that were with hemoglobins less than 7, 7 to 8, and above 8, in green, yellow, and red. So it sets up an internal competition among providers in a department to do better. For example, this orthopedic doc has no red. This one has 80% red. So it sets up a competition to do better. And one thing we learned on our dashboards, these are the 5 hospitals in our health system. We looked at the percentage of red cells that were ordered as double unit transfusions in red or single unit transfusions in green. And we found that 3 of the hospitals, almost 2/3 of their orders were for double unit transfusions. At the other 2 hospitals, not so many. So we started what we call a Why Give 2 When One Will Do campaign for red cell transfusion. So if you went to med school when I did back in the 80s or even the 90s, we were taught that the dose of blood was 2 units. And that was never questioned until Choosing Wisely came along in 2013. And now the experts in the field who wrote the Choosing Wisely guidelines are recommending single unit transfusions and then reassessing the patient before giving more blood unless they're actively hemorrhaging. So we put the Choosing Wisely message, Why Give 2 When One Will Do, on screensavers throughout our health system. And you watch about 10 hand washing awards for all the units in the hospital. And then this would come up talking about single unit transfusions, citing the AABB guidelines for single unit blood orders. And so we've had more success with this campaign than anything else we've done. For example, at one of our hospitals, we had a 50% decrease in the double unit transfusion orders and a concomitant 25% decrease in red cell units per patient. So whether you give your blood at a hemoglobin of 7 or 8 or somewhere in the middle makes less difference than whether you're always giving 2 unit orders versus 1 unit orders. So we even published our Why Give 2 When One Will Do results along with the image that I created in the upper left, which I gave to Dr. Canner for you guys to use. I give it away to everybody because I don't own it. And if you can use that to promote a better transfusion practice, feel free to do so. We branched out into platelets recently, and we put platelets on our dashboard as well. So we have a color-coded report for platelet count triggers, green, blue, pink, red, at platelet counts of 50, 75, and 100,000. So you can see, for example, that in Department of Surgery, almost all their platelets are given with a count lower than 50,000. But in cardiac surgery, though, they give a lot of platelets, even over 100,000. And that's because it's really not just the platelet number, but it's also the platelet function that matters. So if patients are on Plavix and aspirin, for example, like they always are in cardiac, we advocate more platelet function testing. And so we have what's called thromboelastography, or TEG, which is a way to measure whole blood clotting and platelet function. And we use the TEG now routinely in cardiac surgery, transplant surgery, even in traumas now we're using the TEG because you get faster results and you can tell if the patient needs clotting factors like here or platelets like this, and you can get faster results and target your therapy. So I like to say that platelets are the highest risk and cost of all the blood components. They're the highest risk because they're stored at room temperature, so they actually promote bacterial growth. And we average about 1 platelet septic transfusion per year at our institution. We had 4 last year, though, 4 septic platelet transfusions, and one of those was a death. So they're definitely higher risk than the other blood components. That puts the risk about 200 times higher than the risk of hepatitis C or HIV, to give you an example. Platelets are also the highest risk for TRALI, #1 cause of transfusion-related death, because They don't just take platelets from male donors like they do for plasma, and they're just a higher risk. If you can put articles in your hospital's newsletters about your success, that helps the blood management program. Last year we had this article talking about reducing unnecessary transfusions and how we're advancing patient safety and how we saved $1.3 million in 2016. But this year we had an even better year. This article came out last month in one of our journals about the 4 years of results in our blood management program. We had a 20% decrease in red cells, almost a 40% decrease in plasma, and a 15% decrease in platelets. We had our best year ever in 2017 when the whole system was on Epic. So we think the best practice advisories and these decision support algorithms really helped. This is the cost savings for FY17. We decreased our blood spend just about 10%. That's $2.8 million, mainly for red cells, but also savings on plasma and platelets. So we achieved our goal. And by the way, this represents a 400% return on investment for money to support our blood management program. So you do have to spend money to save money because people can't do this kind of work in their spare time. Last two things I want to show are what I call outcomes at the extremes of transfusion. I want to show you how patients do when they don't accept blood. We call these bloodless patients. They get what I call extreme blood management, like Jehovah's Witness patients. And then how do they do after massive transfusion, after you give coolers and coolers of blood? I'll show you how they do. So we have a special program for patients who won't accept blood. We call it Bloodless Medicine and Surgery. We have patients that come from all kinds of distances away because they often get turned down at other hospitals. And we give them all the methods that I outlined: pre-op anemia treatment, cell saver use, tranexamic acid, smaller phlebotomy tubes, what we call meticulous surgical technique. They try harder to reduce bleeding. They get everything. And in fact, we wrote an article called Top 10 Things to Consider for Bloodless Medicine and Surgery. The editor told me more people would read it if we made it a top 10 list. So we did. That was last year. And then we even looked at outcomes. We took the first 300 or so bloodless patients and then compared them to a matched group of controls shown in red. And we looked at ischemic events, respiratory, renal, and thrombotic events. And we found no difference in outcomes and a trend towards less hospital-acquired infections, not quite statistically significant. So we can say that these patients do as well, perhaps better, if you give them what I call extreme blood management. And then how do patients do after massive transfusion? So we took every single patient admitted to Johns Hopkins over 6 years, and we plotted them on the x-axis according to their dose of blood. So over 300,000 patients. Their dose of blood is shown in 10-unit increments, and then mortality is on the y-axis. And it's not surprising that the more blood you get, the more likely you're going to die. That's not really surprising at all. But we wanted to know the slope and the shape of this curve. Okay, so the shape was linear and the slope was 1, meaning for every 10 units of red cells, you had a 10% increase in mortality. And at 50 units of red cells, you reach 50% mortality. So it's like flipping a coin when you get to 50 units on a massive transfusion, whether your patient will leave the hospital alive or not, which is pretty good odds compared to some of the other conditions we treat, like pancreatic cancer, for example. But perhaps more importantly is the types of morbid events that they suffer. So here's the dose of blood again on the x-axis. And it turns out that infections and thrombotic events were way more common than renal or respiratory or ischemic events. So we should be more vigilant to prevent, diagnose, and treat infections and thromboses after massive transfusion in order to improve their outcomes. I'll just finish up by saying that blood saves lives when you need it, but only increases risk and cost when you don't. And that's really the main message of my lecture. And this is surgeon number 44. I did a Whipple with him last week. And I like to say there's 6 P's for surgical bleeding: pressure, patience, prayer, proline, plasma, and platelets, hopefully in that order. And I want to thank all the people that I work with back home from about 13 different departments that are all involved with our blood management efforts. It's definitely a team sport, and if you do it right, it reaps benefits. Thank you.